But then. Yeah, so then we're not muted on there.
We don't want to be muted, I just.
Right,
Okay,
perfect. Right.
all right, hello, everybody, welcome to UPC this month. Who all do we have on here? Stephanie, me, Miranda, I think some other people are coming, so.
Shadow, Wendy, Blues.
Yeah, I think they're all coming on Zoom. All righty, who's doing minutes?
I'm working on it.
You are, okay.
Yep.
Thanks, Kristen.
Yep.
Oh, give everybody a second to get settled here.
Do you want me to find your computer?
Okay, I might see everybody else, so great view.
Yep.
Oh, okay. Thanks, I would know who's talking about it. Here we go. Welcome, everyone. So for our agenda today, we're gonna start, where's my next slide? How do I do next? Oh, okay.
Yeah, okay.
So I wanted to talk about our Press Ganey scores, so thank you for Jamie for getting them for me. So overall, compared, you know, we're kind of downtrending a little bit on some of these things, but like, so if you see like previous quarter 3 in the middle there, we've kind of gone down on everything. So this is kind of overall for our top box scores. This is just kind of our distribution of responses, like positive and negative and mixed ratings to the comments. And then this one here, looks at like our patient experience. So, for nurses, listen carefully to you. We're only like 55th percentile. You can kind of see the percentiles over there. Some of the lower ones, friendliness and courtesy of nurses is 66. Courtesy of person cleaning rooms, 63. I know that's not really us, but we are also cleaning rooms. So, looking for maybe some ideas on how we can increase our Press Ganey scores here and make our patient satisfaction better.
Can I say one thing really quick? Overarching comment is that nurses to our patients means anyone who comes into their room. So it's not, they don't differentiate.
Nurses, DNA.
Yeah.
Okay, good to know. And then this is like more specific here for our HCAT, so, we are better than November, but when I saw November's Press Ganey scores that you had gotten us that I saw, over on the side, they were all down. So overall, we're better from November to December, but I think from October, November, like things were pretty down. Let's see, responsive hospital staff. So that would be like, I would say like your call light response. We're only at 67.22, which is better than we were at 58, but like 67.22% is still pretty low. So I think we could, you know, come up with some ideas or some ways that we could increase our response times. And then of course, like hospital environment, I don't know, like, we don't have specific comments, but, you know, making sure we keep our patients' rooms clean would probably be a good one there, and just, you know, extra unnecessary supplies in the room probably doesn't help either. Communication about medication or medicines and discharge information. Our discharge information is pretty good, but we could, you know, be better about communicating about medications to them. As nurses, we can always add educational material to our discharge list. I know Sarah Dominic's really good about it, but we also can add those in as well if it's not her discharging the patient. So these are just some things to kind of look at here. Not to move on yet, so how do I go back?
I think if you just left arrow, did it not let you do it?
Oh, there we go. So if anybody has any kind of ideas on how we can work on some of these things, feel free to chime in.
I think bedside reporting is gonna be huge, as it always has been, but I always try to encourage it as much as possible because it was, things get missed by accident or whatever.
Yeah.
So I think just
No, definitely. And I know Lauren put that in her bugle this month that I know we've gotten really lax about doing bedside shift report, but it really is important to do. And so I think all of us in UPC and even just on the floor, just holding each other accountable. Us, if you know, somebody's just trying to get a report at the desk, maybe just get up and go to the room and start doing report there. And then also just holding each other accountable at the desk and just being like, hey, like, we're supposed to be doing bedside shift report. I know not everybody's comfortable about speaking up, but just telling your fellow peers like, hey, like, we should all get up and do this instead of sitting here. You know, it's really important for patient safety and, you know, it is important. I've walked into patient rooms before when I haven't done shift report or bedside shift report and, you know, the night shift nurse hung an antibiotic and it was left clamped. Well, then I come in an hour later and I notice it, well, now it's on me because I didn't catch it earlier, you know? And so it's just kind of making sure that our patients are getting cared for the best way they can. And, you know, if their antibiotics an hour late now, and if the night shift nurse, you know, was busy and hung it an hour late, well, now it's 2 hours late, and that's not safe for the patient. So I think just holding each other accountable. Yeah, so great.
I've really been trying to work with the CNAs on responsiveness to call lights and getting everybody and then training the new staff to utilize and answer their phones. But it doesn't just fall on CNAs, the nurses don't answer their phones either. Yeah, because I had a CNA the other night and she's like, I'm busy, because I'd taken acuities down and gotten something to drink. By the time I came up, one of the call lights had been going off for 5 minutes.
Yeah,
And I asked her, I said, is your phone working? And she says, yes, but I'm busy. I said, okay. I said, just, if you answer your phone, that way the patient is acknowledged, they know that you've heard them. And then if you can't get to them, I said, then reach out to myself as ward secretary, the charge nurse, your nurse, or one of the other CNAs. But that way the patient at least knows that they're acknowledged and somebody is coming. But then, like I said, the nurses aren't pitching in and helping answer call lights either.
and that is a big complaint I've heard recently about, there's call lights going off, they've been going off for a while, and there's 3 nurses at the nurses station sitting there.
Just happened, just.
And it's just, and they're not answering it. And there's some nurses that are really good about it, and there's some that, well, the CNAs answer it.
Yeah, I asked, I said, hey, can somebody go after that, like, well, we don't have notes, and I said, okay.
And that's why we keep our whiteboards updated.
Exactly, so I walked in there and she's independent, but is unstable, but she's already up and moving.
And so it's like, you know, I think it's re-educating everybody that we work as a team and it's important that we answer these in a timely manner. I don't know if you've ever done the activity, I've done this in other hospitals where have you sit in a room and someone says, I'll be back in 5 minutes. And it feels like an hour. And so it's just like, what do our patients feel like if they have to pee? And and they have to wait 5 minutes for their call light to be answered. And then they have to wait another 3, 4, 5 minutes for the staff to actually come. That's a really long time.
It's too bad we didn't have call lights to differentiate what they were needing. Like if it's a bathroom, they hit the bathroom light and then.
We do have a couple of call lights.
Yeah.
They have a pain med button and a bathroom button. The patients don't use them appropriately.
The lady in Fort push all of them.
Yeah, you know, and then it's just being all kinds of crazy.
Yeah.
And then the only problem with that, especially if they don't utilize it appropriately, say they hit the bathroom one and they just wanted, you know, they were asking for a pain med or they just, oops, I hit the wrong button. It cannot be cleared from anywhere but inside the room.
Yeah.
You have to go to the room to clear it. So, like I said, and we were just randomly, by fluke, got a couple of those call lights. We didn't specifically order them or.
But if the CNAs were answering on their phone, you know, unless you're dirty and knee deep in, you know, code brown, like if they can, because if the patient's like, oh, I need pain medicine, well, then they can just call the nurse and then, you know, now that call light's done and the nurse can take care of it. But I think like the big issue is like just the call light wait times are so long.
Well, and that's what I'm saying, you know, if the CNA, I mean, unless they're elbow deep, you know, if they at least answer
Mhm.
that you don't have the phone. You know, cause I see it all the time. They will literally get up from the desk and go answer the call light. But I told them, I was like, you know, cause we've had so many discussions about this. It's like to a patient laying in a bed. Even, you know, cause say you're on one end, it might take you 45 seconds to walk down there. Even that 45 seconds from when you could have picked up the phone. You could have been walking en route, but it's 45 seconds sooner than they saw your face or heard a voice.
Mhm.
It's just, it's so that we have the
It's that
phone,
response.
it's that
yeah.
response time, and like you said, laying in a bed, 1 minute can seem like 30.
Microwave minute.
Yeah, to the one that just needs something,
Yeah.
wants something.
So I think,
I think the CNA's staying till 6:30 and actually knowing what they're supposed to be doing time for and 6:30, rather than just standing there with their jacket on talking, would be useful. There are like a handful of them that know what they're supposed to do, but they're the seasoned.
yeah,
This
the other ones are like,
communication
oh, I just hang out till
Yeah.
6:30.
Well, I mean, there's a couple of them just jumping in and they've been very receptive to it and doing it. Like I said, there's been pushback from a few that they absolutely won't stay, they just leave. Or they stand there with the coat and stare at you. Or I had one the other day who I had gone down to answer a call light. And yes, they stayed till 6:30, but they literally sat next to the call light box. And at the desk, not doing nothing, as if you just sat there and writing.
And the whole reason is for them to help answer call lights.
Yes, so that the oncoming shift can get as many vitals done
Yeah,
in that few minutes, cause like, I tried to tell them, it's like, you know, that 10-15 minutes that you guys are here. Or that you're actually scheduled for, we're not asking you to stay over, we're just asking you to stay for the allotted time that you are scheduled.
Mhm.
If you toilet one person in that time that you're here, or you answer a couple lights that aren't toilet, that might be simple something or something else. Your oncoming CNA might be able to get 2, 3, maybe even 4 sets of vitals done. While you were able to do that one task.
And especially with all of our isolation patients right now, we have trays to pass, we have, there's things that they can do, yeah, so.
Talk about your, report. For the CNAs.
Oh, I think, yes, I think CNA should do bedside trip report as well. I think that would hold them.
I think certain people could do it, I don't think. Or maybe not full report, but I think that they.
At least go room to room.
Introductions.
Introduction,
Hey, I'm going home for the day, this is.
at least go in. And then you can see that everything was taken care of, trash was out, laundry, whatever, the patient's not spoiled. And then you're accepting the room as is, cause I've heard a lot of CNAs complain. They didn't take the trash out, this patient was soiled, like. You know, then you're accepting that, just like whenever nurses,
We do
If
it too.
if I come in and the, you know, IV antibiotic wasn't unclamped. My initial reaction is, oh, they didn't unclamp it, but it's like, well, I accepted this room as is when I got a report. And so if I didn't see it, so I think that, and then I think, you know. The patient, then if they haven't been toileted and your shift rounds didn't get done and they have to go, well, here's our chance to get them up to the bathroom.
It's just, I think we'll hold people more accountable, and I think once we keep doing it, it'll be like, oh, Emily is coming in, you know, she's pretty diligent on making sure her rooms are clean, so let me make sure my room is, so I don't have to stay. Her tell me, can you please pick up?
And then we're also anticipating the patient's needs more, so that they're not having to call to go to the bathroom. And I think a lot of re-education needs to be done there with, I think it was, you guys talked about it at your last meeting with, just making sure we go in there, we ask, do you need to go to the bathroom, instead of, do you need anything else?
Oh, right.
Being that deliberate question, do you need water, do you need, and like anticipating these needs, and you will get called a lot less.
It's just like, you know, a couple weeks ago when you went to take in a dinner tray right at 6 o'clock. And you came out and you're like, end of shift round must not be getting done, because the second you handed them their tray, they're like, I need to go to the bathroom.
Yeah,
And so you know, we need to reiterate on making sure.
And it's just gonna make your day run a lot smoother, cause now you're taking the bathroom on your time, your terms. If they're like, well, I don't really have to go, but I could probably go. And it's like, yeah, I have a couple minutes. Well, instead of them calling when you are busy 10 minutes later to go to the bathroom.
Yeah.
You know, anticipating those needs.
So kind of, I just have a question. So it sounds like there are also some like employment issues where people don't understand that this is like a job and that there are requirements of the job. And there are reasons that they could no longer have a job, and that includes not doing your job. So I guess my question is maybe more for Lauren, do you have recommendations for them cause I know it's kind of an art form to like be a person leader, but then at what point do we get to like,
Well, I
this
guess-
is no longer.
My question is, why are they refusing to stay? One. And the other piece of that is, you can tell me privately who it is, because nobody, their clock time is what time they're supposed to be leaving. So if they're leaving this building and then they're not clocking out until their appropriate time and they've already left, then that's a whole nother, that opens a whole other can of worms.
Yeah.
You don't have to tell me right here for everybody. That is something that I need to know, but like, yeah, like there's those issues. But it's like I told Emily this morning, like there are problems that we need to address. But and like the issues and things like with press gaining and like patient scores and communication and all of that. Until we like get this basic stuff like taken care of, you can't move forward and put in anything into place to help this until like you've taken care of like your housekeeping and stuff. And so I think, sorry, I'm all like congested. But so I think that those are things like the accountability piece and like the charge nurses. These are things in the IDM that we're gonna discuss, like what the expectations are about the charge nurses. Because I don't think that the charge nurses are necessarily seen as like a leader and someone who can have that voice, because Emily even said like, well, who am I to like tell them that they have to do X, Y, and Z? Well, you're the charge nurse. I expect that if you're here, you're in that role, that's what you're doing. And so, so I think that laying out those ground rules, and when we have the IDMs, next week, and we talk about like what the expectations are, I think that will also kind of clear up like what needs to be done. And you know, you can't say that, well, it's only okay for, you know, Kristen and whoever else that they're gonna do this, but this person is refusing. But there's no sort of like, nothing's ever done about that person. They're just left to continue to do whatever it is that they're doing. And that may
The accountability thing.
Yeah.
made me a very unpopular person.
And like she was saying, like these basic things need to get done, you know, like I know like oral care is not always getting done. Oh,
Yeah.
The CNA education I did last June, that big room thing.
yeah,
Does that need to be a thing? Like these are your job duties, and because I went over everything, like I still have all the things.
Awesome.
Yeah,
Yeah, well, that's what we talked about
Right.
back in
yeah,
November, because we had talked about.
yeah,
If that was gonna be an annual thing, or it needs to be a semi-annual.
Right.
thing, You know, and it doesn't have to be as long, maybe. every
no, yeah,
time.
just be change in process.
Saving process or improvement, but then you're also you catch a couple new people that maybe they didn't see it, but I think it was very good.
I think it goes along with the Code Blue training. I really like that you're having us do that, because I haven't had a refresher in so long.
Yes.
Stuff like that, but it's just like. And hopefully eventually with time, we'll just, you know, get it, but yeah, I agree, it's just.
Well, because if we're having continual education on these things, then then they can't be coming back to us when we come to them, and be like, well, I was never taught that.
Right.
I didn't know that. I
Yeah,
didn't, you know, I'm getting very tired of, I bring something to somebody, or like I said, you know, and we never, this whole thing, you know, we never tried to go above anybody's head or anything, but I didn't think it was unrealistic to ask CNAs to actually stay for the time that they're allotted, scheduled to be here anyway. And we thought, you know, because we kind of have a little powwow at the desk, a couple of us, a couple of charge nurses, and we're like, okay, what could maybe help bridge the gap between the shifts? Help them, well, first of all, do what's best outcomes for the patient, and then make the CNAs feel like they have each other's backs. You know, they're not this backbiting, not the bickering, not this. So best outcomes for the patients, but like I said, if day shift is staying over, not staying over, if day shift is completing their shift to the time they're to leave, getting these duties done, letting the oncoming shift get a good start, and vice versa, it's a more even flow. We know, and like I said, even though there's been a couple of pullbacks, and we've noticed that for the most part, I know when my night shift charge nurses are coming in, they're noticing a difference. Call lights aren't going off as much during when they're trying to give and get reports. It's just, it's been a lot smoother process just in this, what, 2 weeks that
Yeah.
we've been doing this. Like I said, there's been a little pushback from a couple, but it has gone a lot smoother. It
and
really
even in that
has.
time, like, they say they give report, they come out to the floor, and if they do their meet and greet,
Mhm.
they could even go room to room together. Well, I guess not grab vitals, because that would take too long.
Yeah.
But, do the meet and greet, and then finish up those things, those housekeeping things they might not have gotten done.
Yeah.
And,
Well, and
and it
even-
would bridge that, and
Yeah,
it would be
even
like,
in the
okay,
meet-
we're
even
teamwork,
in the
we're
meet
working
and greet,
together.
If, say this one, they're handing off, you know, I'm handing off, you know, Jamie, this is Emily, she's gonna be your CNA, you know, for tonight, I'm going home. Jamie's like, oh, I need to go to the bathroom. Okay, give us just 2 minutes. I'm gonna finish introducing her right back quick. One of us will be right back.
Yeah,
And then one of you can go back, and then you're possibly gonna encounter that with somebody else. The other one go to the other one, or split off and then be able to go start their vitals and do whatever.
yeah,
Like I said, the meet and greet, the introduction, I think would be good for the CNAs. CNA bedside report, I don't think that would. be
yeah,
there.
just at least a meet and greet, so
Yeah,
you
a
can
meet
be
and
like,
greet,
here you
like, so
go.
introduce each other,
Yeah,
kind of.
like, I definitely think it's more important for nurses to do the shift report, because we're, that's involving them and like what's going on.
That's information that pertains to the
Yeah.
patient, and that gets them involved in the, you know, patient.
The patient plan and everything,
Plan and them feeling involved.
but definitely a meet and greet, I think.
Yeah, I think that would be good.
Awesome. Another,
Oh, sorry, guys. One thing I was gonna say with the CNA meet and greet that we need to be careful of might be that they don't talk about, how do I say this? Anything above their scope as far as like the diagnosis or, you know, or if the patient has diagnostic questions or, do you see what I'm saying? Like, I don't want to set our CNAs up to be in a position where a patient doesn't understand their job roles and therefore asking them a ton of medical questions, and then they try to answer it maybe because they don't understand that they're not supposed, you know, does that make sense? Like, I just don't want to set our CNAs up for that maybe. It just might be something to consider, but
yeah.
I don't know. What are your,
That's why I think for the meet and greet, it would be good, like I said, just for the 2 CNAs, walk in, they view the room, that way they can see, and obviously don't discuss it in the room. If I'm coming on and I see the room is still a mess, I'm not gonna tell Kristen in the room, hey, this room is a disaster. Just have Kristen introduce me, that I'm coming on, we will be back just shortly to start your vitals and all that, we step out. Then I tell Kristen, hey, Kristen, that room's a mess, when we're done, can you go ahead and just finish gathering all the trash and everything? But that's all it could be, is like
Yeah.
I said, visualizing the room, the patient, and an introduction, and then moving on.
Yeah, and I think there's like if even during the middle of her shift, as a CNA went into a room and a patient starts asking questions, I would hope they would say, you know, I'm the nurse assistant, but I will get your nurse to, you know, your nurse will be in shortly to answer those questions. So I think just reiterating that too, like, Yeah,
Maybe one of the action items from this would be to come up with some key phrases for the CNAs. So that they know, I mean, I feel like for the most part, that's like,
Yeah,
it happens pretty well. But I think giving you the language, cause it's weird to say like,
It's forming the dialogue.
right, yeah. I think that could be
Good idea,
a
yeah.
fun action item.
for sure. Okay, another thing I had come up with that I've shared with several individuals on the floor is nurses getting the first set of vitals. You know, we're doing an assessment in the morning with our med paths, and we often need vitals anyways when we do blood pressure meds. So I think taking that role off of the CNAs and maybe having the vitals times be due at like 5, 9, and 1 instead of where they are now. And that way the CNAs come on and they can start answering call lights, getting patients up to the chair for meals, ambulating the early risers, you know, just getting these things done, showers, oral care, these basic things that I feel aren't getting done because they're busy doing vitals, they're busy doing X, Y, and Z. It would alleviate that from them. And then when you think about it, if a patient is protocol vital, so the day shift nurse would get it in the morning, the night shift would get it on their shift. That's one patient they're not having to do vitals on. You know, if they're Q4, they might have to do them later in the afternoon, but it would at least give them 4 hours. More than that. They wouldn't have to do vitals till 1 PM technically, so we would give them all that time.
When I'm a CNA on the floor, when they need me, it takes me sometimes 2 hours just to get my vitals because bathroom breaks and.
Yeah, more.
Messes.
You get to break down those
First round, yeah.
Vitals can take up to 2 hours.
Yeah.
Especially in the morning when patients are waking up, they have to go to the bathroom, you know.
Ordering breakfast.
And technically, you shouldn't be giving meds, blood pressure meds on a blood pressure that was done
2 hours.
Yeah.
2 hours ago.
So it's like, if we're already in there doing our med pass, why can't we just grab a quick set of vitals, even if they don't have blood pressure, like.
It takes out the, you didn't tell me low or high. It just takes out miscommunication and it's just better care.
And yeah, and
I would thought that the like offgoing nurse will have a picture at the end of shift to hand the next.
yeah,
Right, yeah,
yeah,
Which can be done with end of shift rounds.
right.
And then things are.
yeah, but I think that
Would that throw anything off from like the timing aspect?
it really, it's only an hour early. Or an hour late.
Like an hour.
It'll be an hour early, so instead of doing 6 AM vitals.
Oh, yeah, then it'd be at 5.
Five.
But a lot of times the CNAs are starting vitals at 4:30. So it's like, I don't know if it would really necessarily need to be changed on the work list.
Right, because right now the.
4:30 in the
like,
afternoon.
Doesn't have a time, right? So.
For what?
But I think they're visual, if we tell,
No, but
if it shows though, like 5 o'clock, I think it initiates.
I think it,
there's clocks. like,
It's not ended in 14 morning.
Yeah, there's.
yeah, but on protocol, I think it's 6. There's a clock.
Yeah, there's still clocks, but
There's no clock on protocol, I think.
there's clocks on Q4.
There's clocks on
Yeah.
And
Q4.
so of course, like if it's they're due at 2, well then it would just look like we're doing our vitals an hour early each time.
Every.
Yeah. But
Okay, so now you apply to every unit, Susie.
But, you know, I just feel like it would alleviate that.
Would it just have to be ICU and med surg? Or would it have to be SAU too?
They're all the same. Voucher. When it comes from the doctor.
But so are med administration times, and I think that we could really make the case with the other UPCs that, like, this is a really good example of where, like, I think that this is doing the right thing for the patient, because I think that it will eliminate the workflow issue between RNs and CNAs, but also it's the right thing clinically to do. That if we're giving medication without checking a blood pressure, we'll,
Yeah.
Well, take ICU, they're doing it every hour anyway, technically, if they're ICU status, and if they're med surg status, they should be doing whatever they're doing anyway.
Yeah. Well, the thing is, it's like,
solve there, we just have to SU.
otherwise it's like the nurses, you know, CNAs get the vitals at 6 AM. Then the nurse gets the vitals at 9:30, 9:30, whenever they're doing med. Well, then the CNAs are getting the vitals again at 10. It's just redundant. So just let us do the first set of vitals when we're in there anyways. And then if they have all this more time to do these patient, you know, these ADLs. That's gonna ultimately improve patient satisfaction, improve, I think even our discharge stay time, if people are up to the chairs and they're sitting up, like, you know, they're getting, that's therapy basically. They're even just sitting up in a chair, like you're using muscles that you don't use when you're laying in bed. So overall, it would be benefiting the patient, benefiting workflow. So
So Stacy, what would you need in order to change the protocols? And if you don't know right now, we can,
Well, it would have to be an agreement, you know, from every unit switch, but I'm trying to confirm the protocol when all these patients have to be worked.
Well, and I have
Are we
seen,
able to-
well, and it's really crazy because I've seen like Q4. Like right now, our current standard hospital Q4 times for vitals are 6, 10, 2. But depending on when the patient is admitted and when they process the orders, the clocks fall.
It depends
They-
on how it gets started.
Yeah, they default funny, they don't always, there might be ordered Q4, but they might initiate Q4 from when the orders are transferred, not our standard hospital times.
And that's how the provider, I mean, there's two keyboards, there's a regular one, that's on the order, and there's a secret one.
I have to use the secret.
And
It's the secret.
It's the secret. Well, it's just like when you have patients that are on, and we don't have a whole lot, I understand, but when we have patients who are on Q8 vitals, the whole purpose of that is like 6 AM, 2 PM, 10 PM, so you're not waking them up at that 2 AM time. Well, like I said, depending on when the order gets processed, that's when it initiates the Q8 time, so it might set it for 3 o'clock in the morning. It's like, no, that's not the point.
yeah.
So, yeah, that's where the clock.
Is there any way that we can like trial this just on MSU?
How about we try like the month of February, where it's 4 solid weeks,
Yeah. Oh, it's a perfect 4 cell week.
yeah,
You know, and
all
then,
staff will get a chance to do it. And then we could.
and with our
review
turning, you
and go
know,
from there.
it may show that we're doing vitals an hour early, you know, but they're still gonna be every 4
Well,
hours.
they
It
can-
just may not.
They hit the clock, but everybody knows to change it to the accurate
I
time.
think we need to re-educate about that too. 'cause
We do.
Yeah,
We do.
cause if you're getting a vital at
LPN the other
2:30
night.
and you hit the clock, it's saying 2 o'clock.
I had an LPN the other night and told their CNA that they have to document it on the clock every single time. So then I had to explain.
You do.
You document, well, you document the clock, but you have to.
You have to change your time if it's not at.
Because, so you can't be in 6 different rooms doing all 6 sets of vitals at the same time. So if you're documenting every single one of your vitals at 1800, they're falsified. Yes, you hit the clock, but you change it to the accurate.
Well, and also just for, you know, if you did them at 2:30, but you hit the clock and it says 2,
Mhm.
and it's a low blood pressure, and then now the nurse, you tell the nurse, now the nurse is going in at 2:32.
Yep.
Well, it looks like there was
Yeah.
32 minutes where nothing's done, because it
So
wasn't
So that
accurate
needs
time,
re-
yeah.
re-educated too.
Okay.
It's like, yes, you hit the clock, but if it's not right on the minute, then you have to do the correct time.
Yeah,
So I did confirm that protocol does not have a clock.
okay.
Which we don't have one of those anyway.
okay, so just from like a facilitating standpoint, you guys have had a really good discussion, but I think that there were like 6 action items that came out of that conversation that we really need to like talk about.
Okay, action item 1. We got,
Ready to go.
Oh my God.
Whoever.
I
Do
think,
you wanna trial it? That's the first
Yeah.
question.
I think I wanna trial it. What about you guys?
I think we should put it to vote. I'm not voting
For the month of February.
For the
yes.
Month of
I
February,
think-
trial, nurse is getting the first set of vitals of their morning med pass and assessment.
Yes.
Yes.
Zoomer.
Zoomer,
Yes, nays?
that's Wendy, she's at the climbing gym with her children.
I'm
Yeah,
good,
let's
I'm
do
good
it.
with trialing it. I think
Okay.
it would be good to trial,
It's just like a.
as long as
complete-
everyone's.
Yeah, if it's completely awful and we're like, this is not working, then yeah,
So we're gonna trial 9, 1, and 5.
9, 1, and 5, yeah. That way, when we're doing our vitals, anywhere from like 8 to 10, you know, we got a set of vitals in there. And then, you know. I like it.
Yeah.
And then
Weeks to
figure out how to put this out,
Yeah.
put this into play.
Well, and we've got the IDM coming up, so Lauren can address it in the IDM.
Perfect. Action item 2, just re-educating about the vital time at the right time.
I think we just need to put that in the DM. and
Yeah,
I can put-
okay.
And I can put it.
Well,
in
and
the-
that's not just vitals,
Perfect.
rounding, all of it.
Yeah.
Just documentation.
Just documentation,
Documentation.
period.
And then re-educating about if you're sitting at the nurse's station,
Answer the
the
call.
answer the call. And that's like,
Easy phone, and if you're sitting next to it.
yeah. so all these things are, a lot of it's just re-education, things I think Kristen said like, oh, yeah, we come out with that and then we do it for a few months and then it just kind of goes.
Well, and kind of to backtrack on that one, sorry to backtrack, because Morgan was working on, we talked about it in November. Getting it changed to be able to put in the orientation manual, that there is a section that covers
Mhm.
expectation of answering call lights for both nurses and CNAs. That explains how, yes, it goes to the CNA phone first, within 30 seconds, then it rolls to the nurse's phone. It should be answered between one of them in a timely manner. If neither of them can get it, then either the charge nurse or the secretary grabs it. And so Morgan was working on,
And she did send it to me and I
Yeah.
have it in my email.
yes, so anyway, so that would then kind of go with. the
Yeah.
action plan.
But I think that would be good to add.
It would, like I said, we need to reiterate it for our current staff, but then going forward, it would be good.
Sweet, I think we only really have the 2 action items.
No. So a preceding factor to actually putting this into place, I think, is talking to your providers and making sure that they're okay, that their last set of vitals was obtained at 5 o'clock and then that their next set of vitals will be obtained at 9. Because I remember vaguely in UPC like 5 years ago where we moved vital times around and the providers threw a huge fit.
I think we moved it to 8, noon and 4, and I think it was that weird 8 o'clock.
I just think getting them on board is gonna really help in the success or failure of
Okay,
making, I understand it's your workflow, but they also need that clinical data as well.
but I feel like in the morning, the vitals are at 6, but I've also seen a lot of vitals done at 4:30 because they started super early.
No,
So it's like-
that's not super early, that's getting them super late.
Yeah.
That's the, should be
That's the
done,
two-
that should be done at 2 AM.
Are those the 2 AM
Yeah,
ones?
those are 2 AM,
Oh.
I'm getting
Oh,
done.
okay.
Yeah, that's not being done super early.
I thought they were,
No, that's being.
oh
done
yeah,
super
because they were,
late.
so day shift gets 6, okay,
Yeah.
never mind, all
No,
right,
that's
okay,
getting done super late.
gotcha, okay.
I mean, I understand that it makes a lot of sense for the rest of the team, but if you don't have your providers on board, it's.
Well, because if we can.
Could potentially-
Providers, because if there's a 5 AM set, when they're coming on, then there's a pretty current set.
It's still pretty current.
And
yeah.
then there's going to be a set, a 9 o'clock set
From your nurse.
from your nurse to reflect for blood pressure, for meds, for med
Yeah.
packs.
And this could also help with what you and I have been working on too. So Stacy and I met, after we had an incident where a patient went and there were no vitals that were recorded for like hours upon hours. And yeah, for a post-op patient. And so we're gonna do some re-education about what post-op vitals are and roll out some things just around vitals in general. But Stacy's been working on building, in Meditech when the CNAs like chart their vitals. Let's say you put something in that's abnormal, it will highlight it. It will give a message that you have to tell the nurse. Then it will give you a task that says, I did notify the nurse that this was abnormal. So on those Q4 that they are doing, at least there's something that's going to alert them. And that they have to follow up on the document that they actually did tell the nurse.
Nice.
And it was like I don't know like how, we'll do it, but we can also like track what time they did the vital versus what time they acknowledged that they told the nurse.
Kind of like our critical value reporting for like labs and stuff.
Yeah.
It says all that, like,
well,
who was notified
I know
at what time.
Cause it was gonna be within the same document.
Oh, yeah. It wasn't gonna be a task, it was gonna be.
Yeah.
So then the other thing is, how are you gonna garner if it's a successful or not? Like after this month, how are you gonna know if it's something you're gonna continue or not?
Survey.
That's a definitely legitimate way to know that.
Like just ask everybody, does this work for you? Did you feel like
It's improved your work.
you improved your workflow, patients had it, you just were able to get more stuff done?
You can add it to patient rounding, so like,
Yeah.
when I do leader rounding, I can ask like, do you feel like everything's being answered in an appropriate time?
Yeah.
You know, are things being taken care of? Are you getting bathed, sort of things? But then I think also like, looking at your documentation of, are more baths getting done?
Yeah.
Are patients ambulating
More
more? Is their mouth care
quantifiable.
being completed? So like you can do a survey of, does it help improve the workflow? But then also like, what's your data for like patient care?
Right, because does that mean that more people have more time to get coffee? Or does it mean that our patients are getting more care? And I don't mean that as like a point, I just mean,
Yeah, Yeah.
And
Is that
just
extra time
sometimes you're
being
busy
used?
doesn't
right,
mean.
is it being used efficiently? Yeah.
Well, and there needs to be, when this is rolled out, there needs to be some specific guidance in this on, okay, CNAs, you don't have the responsibility of your first set of vitals to do now. So in the mornings, you have time to get people up in a chair for breakfast, help them order breakfast, start ambulating, all this kind of stuff.
But for those,
And at night, you have, this, it's not, okay, you have this 4-hour window of, yes, I have time to go have coffee now.
yeah,
Whatever.
one with those patients that do like to bathe before bed, I feel like it's hard to get that done in the evening because they are doing vitals and this and that.
Well, I think it
And
would,
so I think it'll,
and it would help too with our one-to-one feeds.
exactly.
You have a patient who has one-to-one feed, they can be doing that and not having to be worried about doing that first set of rounding vital, that's huge.
Yeah.
So how and who,
you and I.
Is there a way to like look up in Meditech or whatever, like create a report on like how many baths got done or no?
oral care, or, because like I said, it's in the rounding documentation.
So there's no way to like say how many times.
That has, rounding, it will just say, for patients that are currently in house, if rounding was done. Like when the last time it was done, how frequent it was done, but it doesn't pull any of the data inside of that intervention. That would have to be a custom report, and it doesn't sound like, there's any more being approved.
So maybe we can do like what you talked about and having a sheet like the ICU does, whereas if you give a bath, you come and maybe it's at the charge nurse's desk and check off that so-and-so got a bath.
So like day shift and night shift, they keep it at where the ward secretary would sit. If we had one. But anyway. They have a sheet on the front, it has all the rooms, and on the back, it has all the rooms. The front is days and the back is nights. And so day shift will go through and like, when they bathe somebody and they do mouth care and they do X, Y, Z, they mark it off of their sheet. And then like the charge nurse at the end of the day signs the bottom of the sheet saying this is what with her. Night shift comes in and they flip it over and they document their stuff. So like you can see from day shift, who was bathed, who had all their stuff done. But then on night shift, when they do their stuff, then they can mark, like if they do somebody's bath or if they do someone's mouth care.
Yeah. And I think that would be a good idea, because then you could visually see like, okay, like. Who hasn't gotten a bath in 3 days? Like, we need to really, even if they're telling you no, we can like really try to get them. So,
Unless they're not allowed to have a bath when they're supposed to be getting white comes. There'll have to be some way to track which patients are those.
Yeah.
There could be quite a few if they have a line.
And I guess you could even have a CHG on there as well, just
I think that they do, I think, when we get done, I can go up there and get. a copy of what their sheet is. But they have one of those, but then they also audit each other's documentation, like the CNAs audit another CNA's documentation, so it's not just the nurse that does her audits. And So that, okay, well, on this night, I did the chart review and the bath that was on the sheet that said it got done wasn't documented on the chart and. So forth too.
I think this is a lot of stuff. So maybe we focus on like one for the month of February,
On what?
one like action item, or one or two.
So I think that you can, I think the rounding for the CNAs and like making sure they know about the documentation times. And documenting like baths and doing that sheet, I think that that's something easy that you can
Okay.
walk away with and do. You're probably gonna have to submit something to Dr. Tobin. And maybe, I don't know, you can talk to Dr. Kennedy and maybe Dr. Brooks and, or not Brooks, but, Morse and ask them how they feel about the vitals being that way. But you probably will have to submit something to Dr. Tobin to
Okay.
get like his blessing that it's okay, would be
Okay.
what I would
My
assume.
initial thought was really just talking to the hospitalist team, because that's where the majority of the patients are, but you're right, that there's like, there's all different kinds of, but they also have post-op. I mean, most of those people have post-op,
Yeah.
but,
True, and then it'd be from.
right, then it would just go into our protocol, which I don't think that they had really any say on setting up in the first place, but what do I know?
No, and
Well, most of them that are rounding that early, like I said, they're, the vitals that they're gonna see from 5 a.m. are gonna be much sooner than what they're looking at the last second
Right.
2 a.m. You know, because a lot of times when your physicians are coming in at 6, the CNAs are doing vitals now, so they either
Right.
haven't got them documented yet, haven't got to it yet. So there is going to be a fairly fresh set that the early rounders, physician
Right.
rounders are going to see.
Well, I'll email like the hospitalists and maybe just the general surgeons. And if I get any pushback, then maybe we need to discuss it more, but if they're just like, yeah, like, then I can just maybe send an email out to doctors.
well, and we have critical care meeting on Wednesday evening. And the hospitals come to that. You're more than welcome to come and just like present this as this is what we would like to do. And talk about it there too.
Okay.
Since you will have. And it's like. McTabby will be there, Kennedy comes written in meetings, and Dr. Tobin really is there.
Oh, perfect, okay.
So,
What time on Wednesday?
it's at 4:30.
Here on Wednesday.
Right.
Yeah.
Okay, if you need someone to cover you, so that you can go, let me know. Okay.
Sweet. Any feedback on anything?
At some point, we would need to look at the feedback.
Yeah, I can look into it, but I think this is a good starting point. All right,
I have another meeting in 2 minutes. Do you guys need?
no, I think so.
Thank you, Jason.
The next, bye. The next thing on our agenda here is like an acuity tool. I feel like acuity has been high recently, and just to make it, more even, so this is one that I found from myamericannurse.com, and this is the acuity tool they use, but this is an example over here. It just showed like nurse A and like their patient's acuity, and the difference between the highest acuity and the lowest acuity was 6. So it just shows like, and this was before, to show the inequality. So I know Lauren gave me, ICU uses this acuity tool, to help like with the charge nurses making assignments to make it more even. So I would like to try to maybe develop something that pertains more to MSU to help, you know, make assignments more even and kind of more appropriate, like for staffing. And I know we staff like, you know, day shift max of 4 patients, night shift nurses have a max of 5. But then I'm thinking, you know, maybe we could start staffing based on acuity instead of,
I also think it'll help the charge nurses making. it.
Oh, yeah, no, for sure,
It'll
for
take
sure.
like so much time off your hands.
Yeah. Um,
Well,
So I think-
most charge nurses, at least the day shift ones, I can't speak for the night shift because I'm gone by then. But like you guys typically try and meet with your nurses to get any updates to then help you do staffing. Well, sometimes they don't have time to meet with you right then.
Yeah.
So if you set, say by like 4 o'clock, that they need to
the thing is
have
with,
this filled out so that you can.
yeah, they would have to have like something filled out, and so I was, something like, something like this would be a lot easier and quicker to fill out than like ICUs, but I do like how like this is kind of, more specific, but I think maybe trying to come up with something incorporating the two. Cause I feel like this is a lot for people to like fill out. I mean, it would be quick, but like for them, go through. I don't know, you guys have used it a lot more, but your unit's also smaller down there.
I mean, you have to remember, they're only filling it out on 1 to 3 patients,
Yeah.
whereas you guys are gonna be 4
4
or
or
5.
5, yeah. So,
And I think that you wanna come up with something that is going to give a true picture of what the patients are.
yeah,
And that is very, like, the data that is on there isn't just someone saying this patient is busy, so I'm gonna score them the highest that
it's
they,
quantifiable.
because. And I think that that is where there is some disconnect in acuity versus the busyness of the patient. And what does acuity mean, and how, having a patient that has, 27 meds versus, someone who is just on their call light all the time, like what does that look like?
Mhm.
But like, if you have this, then okay, well, this patient is on Vapotherm, they have a heparin drip going, they have this, they're in isolation. They have meds that are all of these times, they have, so many IV medications. Okay, well, they truly are like a high acuity patient versus the patient over here that's just a little bit more needy than the other. So,
Does it account for that neediness? Because
So,
that is
I
still a
think-
real thing.
so I do think that there's somewhere, I don't know if they put it on this one,
I don't remember seeing it like that.
but the one that we use at UT, they actually had, like on there, like. I don't remember how they worded it, it wasn't like neediness, it was like frequent attention. And, but also, like, you also have to take into account, not just that, but behavioral wise, so like, if you have someone who is just like belligerent and just, mean and yelling at the nurses, and it's like, because that also like plays a part in just being
Burnt out,
exhausted.
yeah.
So like, that needs to be, included in there. And maybe you just have that underneath like your.
And
remarks.
with the thing that I'm gonna be working on, we could even add that to the acuity for it's like a workplace violence, but for maintenance. I'm gonna be presenting to the leadership people, but that could also be something, an acuity. Like if they have a lot of behaviors,
Yeah,
then they would.
Yeah.
check
Like
mark
you
the box
could
or
like
whatever.
put whatever
Their
their number
number.
for is into the acuity
Mhm.
sheet. That'd be cool.
But right
Like,
now, like
liter-
when making assignments, it's just the nurse being like, yeah, they're a really heavy patient.
Uh-huh.
And it's like, well, what's heavy to you may not be heavy to this nurse. And so this definitely gives it a more quantifiable, but we do need to take into account like
The demented patient.
yeah, like, yeah, I think this has like confusion, but like, I think we need to take into account also like,
Behavioral.
yeah, the behavioral, more,
and something that we're gonna work on is like behavioral contracts and what is involved in all of that, and. So that putting the behavioral needs on here and what their score is and how that's being handled, I think is
Yeah.
a good idea.
Is whatever the acuity sheet they used from UT, is that like a proprietary acuity sheet? Is that something that you could confirm on?
I mean,
Probably
I-
not.
Yeah, I can.
Okay. Oh, you could.
Or at least show us what it is and we can like tweak it to our floor.
Yeah, so we had two, we had one in ICU and then we had one on the step down unit. And, but we developed our own on the step down unit because we did not have anything at all. And like, the one that we used, because we had a lot of patients that were on drips and they had chest tubes and just a lot of things going on, and you didn't want to give a nurse like three fresh post-op patients that all had chest tubes, and then you had another patient that maybe they were on a drip, and you had one that was an IVDA, which is IV drug abuse patient, and they were on behavioral contracts, and like with those contracts came a whole other like they couldn't go off the floor, they had to wear a special gown. When you went in, like, they couldn't have, obviously, just like here, the straws, no, like, they couldn't have cans, they couldn't have anything from the outside. They couldn't have any of their personal belongings, they couldn't have their cell phone for 7 days, like, there was a lot, and so. To have one of those patients plus all this other stuff, like, it was just overwhelming. And these nurses also had 6 to 7 patients. So, yeah. So we had to come up with something that was able to give them some sort of relief to their load. But I can get it for.
I think this would also help with like giving like LPNs appropriate patients as well. If we can see like, it just at a glance, because otherwise I'm going through charts like, okay, how many IV meds do they have tonight and stuff, so.
Yeah.
You could even have a section that's like LPN consideration, and
Mhm.
it would be like. All of those things, like, does the patient, have they already had their first dose of antibiotics? Or,
Yeah,
you know, whatever.
yeah. Does anybody wanna like take on kind of maybe trying to develop some, well, I guess we can wait for that one, but does anybody wanna take on like, I would like to help with this as well, so we could like create a little group to make something that would work for our floor. You can email me. You.
Nobody offers.
Okay. I just mean not collaborative, yeah, instead of just like just one person making it like collaborative,
Yes, this sounds great.
or at least like somebody come up with some ideas and we're like.
I will help you, but I feel like I just kind of go without the hay.
We're just about out of time, but the last thing like is really just kind of like our staff morale has been pretty low lately. Even like I came into a couple hours early to work on like UPC stuff and just walking onto MSU, I just heard a lot of complaining and people just kind of like, you know, run around like chickens with their heads cut off, but just like heard like a lot of negativity. And I know there's been a lot of illness, people are getting sick, it's like flu and cold season. I know I struggle with mental health issues and a lot of you have shared with me as well that you struggle as well. So I know we're trying to give each other grace with that. You know, I've heard that Ashley leaving has been a morale buster. I know we all loved Ashley. We do have a lot of like higher acuity or, you know, needy patients or whatever and lots of isolation right now. And then I've just also heard a lot of burnout from people not getting enough help. And this is both from the CNAs and RNs. And that kind of goes back to like CNAs not feeling supported by the nurses when they're just sitting at the nurses station, not, you know, answering call outs. So, we can talk about this more at the next meeting, but, like just kind of what can we do to fix it? I've kind of thought about maybe turning our lactation room into a relaxation room. And seeing if we can maybe get, facilities to take the computer out. We don't use it. I don't know if we need it for anything, but maybe turning that into like a
I
more,
think we have to have a lactation room.
but it'll still be a lactation room.
Oh,
They can still lactate in there. Just be careful.
Maybe even better. Cause
Right.
there won't
So
be,
me and Jesse are actually gonna work on, cause we did Zendens at the Pathway Conference. Did some research on that. And she wants to work on doing some wellness for the whole hospital. So
Mhm.
just so you know,
But I think, yeah, awesome.
That's
But
just-
Lauren said they like downstairs, they have like a little,
So in our lactation room, we got a new recliner, platter.
Yes.
And It's one that can be wiped down, obviously, but what was in there was nasty and
Yeah.
gross. And so we got a new recliner, we have like a little thing that diffuses like lavender. in there.
Yeah.
And, well, one, because we wanted to make it like better for, like, there's lactating and like needed to like pump or whatever, like a place that they could go and relax and not feel like they had to like rush, but also like if you just need a minute to like take a breath and like get off the unit and not be in the break room, then you can also use the room. I just ask that everyone takes care of the room.
Yeah.
If you need that, but yeah, we did just kind of add that extra like little stuff in there just
Yeah.
to make it.
And like what gave me this idea was the last hospital work, it was like during hospital week, and we made this like special room and it had, you know, like a little massage thing on the chair, you could sit there, and I think, you know, just if you just are having a bad day and you just need a couple minutes and somebody can watch your patients and you can just get away and breathe.
Vail Health has a really good evidence-based project that I've been looking into, and it's exactly what we're talking
Yeah.
about, but perfect. But, yay.
Yeah, I think that, you know, we can do, I mean, whatever you all,
I mean, we don't use that room for anything, so I feel like let's.
I feel
utilize
like
it.
right now
Good.
that if you're pumping in that room, you feel like you're pumping in someone's office.
Yeah.
So who owns that room?
Technically, it's whoever the manager is. Because technically that would be.
And I feel like they would love the window in the.
I laugh, but the office,
The closet.
Yeah,
yes, but
bye you guys.
what is in there, the furniture that is in there now. We could take it out and, you know, put a chair in there.
Put some pictures,
All that stuff.
change the light, like a blue light in there.
Well, I think like just even like a soft light
And a
lamp in
lamp.
the corner, yeah. Just some
I need
ideas,
one of
so
those. Actually,
we probably have to get this approved or something, but.
I need to just leave it somewhere where I can just.
Put it in your pocket. Little-
So, if people could keep coming up with ideas for staff morale and just for the people on here, like at work, trying to keep a positive attitude. Positivity and negativity, I feel like are both infectious, so, you know,
No energy vampires.
no energy vampires allowed, but, you know. Yes, Morgan.
Sorry, I don't mean to interrupt you guys. So what about like a staff survey? Would that be advantageous to ask them, like, and have them be as specific as possible, but like, what do you need that we can actually help with? And it shouldn't be like ambiguous, like, well, you know, I just have really hard you know, it should be something that we can actually fix potentially. I don't know if that would be something,
think
but maybe put it back on the staff though, to tell us,
Having like an
what do you
anonymous-
need?
Yeah.
Yes, anonymously, yeah. But
Well,
just an
that-
idea, I don't.
And also like so starting this week, I'm gonna hang up on my door like for y'all to do like the one-on-ones. And during that time, like if there are things that you don't wanna share, like out in the open, that is like Vegas. And so you can share whatever you want to share in there if there's something that you feel like you need. For the most part, I've not received a whole lot of like pushback if there's like equipment needs or anything that we need to get. So like if there is stuff that like, well, this has been like torn up for a while or whatever, then just like, let me know, we can work it out, so.
Sounds good.
Kathy has a list.
All right, well, we've gone over our hour, but, I think the survey is a great idea. I bet we can make one even like an online one, like an email. And that way it's not like handwriting or anything and people can send it. So that's a great idea,
Hey,
Morgan.
Emily, who's on Zoom besides Morgan and Lee?
Miranda, Lou, Wendy was here. She's still here. Is that everybody?
That's all I had. I had Wendy,
Oh, yeah, 5 participants.
Morgan, Miranda,
And Wendy was there. Oh, and then Stephanie, Graham and Tina are both on like listening in, I guess.
Right, but Luce, Morgan,
Stephanie.
Wendy.
Graham
Miranda Hernandez, HR.
Oh,
on CNA.
I'm like, but I don't need her, do we need to put her
baby.
in the
Yeah.
minutes?
Yeah.
Anybody who comes, so you do still need to include, Lauren and I, even though we're not
Right,
board members.
So, sorry.
All right, I think we're finished.
Who else was in there? Stephanie Graham, you said?
Stephanie, Graham and Tina, they're working, but they were trying to listen in. So they both texted me and. Thanks, guys.
Thank you, guys.
Thank you. How do I stop video?
Let me know, I know I'm not on the floor often, but